Καλησπέρα σε όλες και όλους που για μια ακόμη φορά επικεντρώθηκαν στην σειρά των μαθημάτων Health and Religion για να ακούσουμε έναν ακόμα σημαντικό εισηγητή με ένα πολύ ιδιαίτερο για όλους μας γιατρούς και μη θέμα που έχει σχέση με την πνευματικότητα και την θρησκευτικότητα στην ιατρική και ποιος είναι ο ρόλος των γιατρών σε αυτήν. Σήμερα έχουμε την εξαιρετική τιμή και ευκαιρία να έχουμε μαζί μας έναν από τους κορυφαίους Αμερικανούς καθηγητές από το Πανεπιστήμιο του Harvard, τον Professor John Peteet. Professor Peteet τελείωσε την ιατρική σχολή στο Πανεπιστήμιο Columbia και μετά έκανε την εκπαίδευσή του στο Πανεπιστήμιο North Carolina Chapel Hill, αλλά κυρίως εκπαιδεύτηκε στην ψυχιατρική στο Massachusetts General Hospital και στο Massachusetts Mental Health Center. Σήμερα είναι ψυχίατρος στα δύο μεγάλα νοσοκομεία του Πανεπιστημίου του Harvard, το Brigham και Women's Hospital και το Dana-Farber Cancer Institute, και το έργο του είναι πάρα πολύ σημαντικό, όχι μόνο στην ψυχιατρική, αλλά ακριβώς αυτό που συζητάμε και θα συζητήσουμε και στα επόμενα μαθήματα, δηλαδή στη σχέση μεταξύ υγείας και θρησκείας. Το 1978 ξεκίνησε στα πανεπιστημιακά νοσοκομεία του Harvard για να κάνει την κλινική του εξάσκηση σαν διευθυντής της ψυχοσωματικής ογκολογίας και αργότερα σαν διευθυντής του προγράμματος για την ψυχοσωματική ιατρική. Μάλιστα, το πρόγραμμά του στο Psychosocial Oncology και Palliative Medicine είναι από τα πιο περιζήτητα προγράμματα μεταξύ των φοιτητών. Εκπαιδεύει πολλούς κλινικούς γιατρούς στα θέματα πνευματικότητας και θρησκευτικότητος. Από το 2006, μαζί με άλλους καθηγητές από την Ιατρική Σχολή του Harvard, έχουν οργανώσει το Harvard Initiative on Health, Spirituality and Religion και παρουσιάζουν με διάφορες ομιλίες και βιβλία αυτά τα δύσκολα θέματα, τα οποία πραγματικά προσπαθούμε και στις ομιλίες αυτές να ενώσουμε. Ορισμένα από τα βιβλία του είναι Eastern Religions, Spirituality and Psychiatry, an Expensive Perspective on Mental Health and Illness. Ένα άλλο βιβλίο του πολύ σημαντικό, Handbook of Religion and Health, Christianity and Psychiatry, Antisemitism and Psychiatry, Spirituality and Religion within the Culture of Medicine, From Evidence to Practice, Depression and the Soul of Medicine, Spiritual Perspective and Clinical Practice και πάρα πολλά άλλα. Είναι Past President of the American Psychiatric Association Caucus on Religion, Spirituality and Psychiatry. Έχει δεχθεί πάρα πολλά βραβεία, μεταξύ των οποίων το Oscar Pfizer Award, και συνεχίζει να είναι ένας από τους leaders στα θέματα αυτά, όπως παραδείγματος χάρη το Physician Assisted Dying, το οποίο είναι και αυτό ένα από τα hot θέματα και της εποχής μας. Νομίζω ότι είπα αρκετά και it's a great honor to have you with us, Professor Peteet. I want to thank you and express my gratitude and the gratitude of the Greek physicians and theologians and other people that are more and more interested on issues related between health and spirituality and religion. And we are anxiously waiting to listen to your topic entitled Spirituality and Religion in Medicine. What is the physician role? Thank you again very much. The floor is yours.
Thank you very much, Dr. Lynnos, for that kind introduction. I very much appreciate this invitation. Let me see if I can share my screen. Are you able to see that?
Yes.
Okay. So I would like to cover this territory of spirituality and mental health by starting with some history, talk a little bit about the DSM classification, a bit about assessment, then diagnosis, some ways that this comes up in treatment, then a little bit about clinician well-being and effectiveness and psychiatric education and training. I don't have to tell you Greeks about the history of spirituality and healing. The Temple of Asclepius and other places were sites where priests engaged in healing, and people thought of healing and spirituality in an integrated way. The first hospitals were in monastic communities. Nuns served as nurses. But then in the Enlightenment, with the advent of empiricism, reductionistic explanations, scientific advances, there was a shift in the Western view of the self. Charles Taylor talks about this in his book, A Secular Age. And then in the post-Enlightenment period, we had models of the mind advanced by Sigmund Freud, B.F. Skinner advocating a behaviorist perspective. And then in the decade of the brain and the biological revolution, we had what we still have today, a lot of emphasis on a biological understanding of the mind. And this was so important in American psychiatry that there were papers published asking whether religion was taboo in psychiatry. These are a couple of papers authored by David Larson, looking at the psychiatric literature for religious variables, 1978 to 1982, and then again 1991 to 1995, concluding that there was a lack of attention to religion within psychiatry. And when it was addressed, the variables were not understood in a very sophisticated way. And yet we know that religiousness has been fairly stable. This is a recent slide looking at evidence from the Pew Research Center, where we can see that in the US, 71%, around 70% now, identify with a religion. 48% say they pray daily. 45% say religion is very important in their lives, and 33% say they attend religious services at least once or twice a month. And in fact, in the last few decades, there's been a greater recognition of the role of spirituality in medicine. 12-step spirituality is widely valued in the recovery community. Palliative medicine includes spiritual care among its goals. Psychoanalysts better understand faith than in the time of Freud. Anna Maria Rizzuto is an example of this. Mindfulness has become mainstream. There are courses, papers, and books increasing. Just last week, there was a global conference on mental health and spirituality here at Harvard, which had almost 400 attendees. Researchers study the neurobiology of spiritual experience. Spirituality is seen as a risk or protective factor. The Joint Commission in the US mandates routine spiritual assessments in hospitals. And most patients, when they're surveyed, say they want their religion or spirituality included in their therapy. The American Psychiatric Association has created a mental health and faith community partnership with an online guide for faith leaders to understand mental health conditions better. The WPA and the Royal College have statements on the relevance of religion and spirituality in psychiatry. And research has burgeoned into religion and health outcomes. This is an example of Harold Koenig's third edition of the Handbook on Religion and Health. And then a paper by Tyler Vanderweel and his group showing a 5-fold reduction in suicide in regular attendees at religious services in this large-scale study of women in the US. In the Diagnostic and Statistical Manual, which is the official publication of the American Psychiatric Association classifying psychiatric disorders, there's a Z code for a condition worthy of attention or treatment, not a disorder. This category can be used when the focus of clinical attention is a moral, religious, or spiritual problem. Moral problems include experiences that disrupt one's understanding of right and wrong or sense of goodness of oneself, others, or institutions. This is a recent addition from last year. Religious or spiritual problems include distressing experiences that involve loss or questioning of faith, problems associated with the conversion to a new faith, or questioning of spiritual values that may not necessarily be related to an organized church or religious institution. And then in the outline for a cultural formulation in the appendix, we see there's an encouragement to look at other clinically relevant aspects of identity that may include religious affiliation and spirituality, socioeconomic class, etc. So there's some greater recognition in the official documentation. So what does assessment entail when it comes to spirituality? I think it's important to recognize that assessment of a person's spirituality can deepen our understanding of a patient's core values, the culture they come from, their object relations, as Anna Maria Rizzuto wrote, their trauma history. There's such a thing as religious trauma, the resources and practices that may be helpful to them, and supports in terms of community as well as faith itself. There are a number of standardized assessments for screening for religious and spiritual issues, and also doing brief assessments. I mentioned the DSM outline for a cultural formulation, which has suggested questions. There are a number of screening tools, the FICA, the HOPE, the FACT, which ask simple questions about the relevance of spirituality to a person and whether they want to have that included in their treatment. And some of these, such as the FACET SP, are used primarily in research. But I usually like to think of the essentials of a spiritual history as beginning with listening for what the person tells you in their story is most valued, sacred, or deeply troubling to them, including in the patient's use of words like courage, despair, comfort, suffering, and peace that can give you clues to what matters most to them. And then asking about the most important aspect of their background or identity, if it's not so clear. And just, have you been a spiritual or religious person, is a helpful question in our context. The person can say if they are, and then you can ask in what way. Sometimes it makes sense to actively explore by following up on practices that a person says are helpful to them. If they mention their relationship to God, how do they envision God? If they mention struggles such as with guilt, disappointment, or doubt, it can be helpful to explore and show an openness to hearing more about what may be important issues for them in terms of their relationship to their faith. And when it comes to differential diagnosis, we're often in a position or sometimes anyway, in a position of just trying to distinguish whether someone is having a dissociative or psychotic state or something that could be better understood as possession in religious terms. Scrupulosity is OCD within the context of a spiritual person's life and tradition, distinguishing that from the faithful practice of rituals in a more ritualistic tradition. Hearing God rather than making a diagnosis of a psychotic hallucination. Tanya Luhrmann is an anthropologist at Stanford who has studied voices in cultures where it's normative for people to say that they're hearing from God, as compared with cultures where, or settings where psychotic illnesses are manifesting as psychotic hallucinations. There's a lot of attention in some parts of the world, such as Brazil, on mystical, anomalous spiritual experiences and how to distinguish those from psychotic experiences. And then, of course, religious delusions regarding guilt are sometimes hard to distinguish from beliefs that are shared by a community. Some of the clinically significant problems that can present when it comes to spirituality and mental health have to do with spiritual manifestations of psychiatric disorders. I mentioned scrupulosity and religious delusions. There can be religiously based resistance to treatment, a so-called spiritualizing style, in which a person is believing that prayer is the solution to their problems rather than medication. There can be problematic family or social manifestations of religion or spirituality, family pressure to adopt a certain stance in the context of a medical illness. There can be spiritual abuse where there's a religious authority who's dominating and abusing their power. There can be distressing spiritual struggles, which Ken Pargaman and Julie Exline have described in their book on religious struggles, spiritual struggles. And these include negative feelings toward God or a higher power, worry about evil spirits, confusion or questions about religious or spiritual beliefs, guilt or moral indecision, and questions about the meaning of life. There can be a range of clinicians' involvement in spirituality and dealing with these kinds of issues. Someone who's basically competent might include these in their assessment and formulation, as opposed to avoiding them, which can also happen. Someone who's spiritually conscious might recognize the needs for help with these issues and make referrals to resources. Someone who's more sensitive spiritually might actually try to integrate and collaborate with outside resources. And some spiritually oriented therapists might engage in spiritual direction, pastoral counseling, healing prayer. Some of the relevant features of the clinical context that can point one in the direction of one or more of these approaches would be the nature, primary aims, and timing of the work. If we're evaluating someone in the emergency room, there's going to be limited time to explore these issues and do much. And if a psychotherapy is primarily focused on another issue, it may not be relevant. So we want to look at the role of spiritual factors in the patient's life, presenting problems, and attitude toward treatment to get an adequate picture of the context. How much concern does the patient have to integrate their emotional and spiritual experiences? Some patients come to therapy with the hopes of doing that. And then the availability of religious and spiritual resources. Is there a person in the patient's tradition who has some psychological appreciation for these issues to whom we could refer the patient? Or if they've been alienated from their church community or their synagogue, how much do we have to take on ourselves in helping them understand the nature of these struggles that they may be having with their faith. There's no one else available to do it. And then when selecting an approach to integration, I think it's helpful to consider one's own knowledge and style, to acknowledge the problem. One option is to acknowledge the problem, but limit discussion to its psychological dimension. Another option would be to clarify the spiritual as well as the psychological aspects of the problem, suggest resources for dealing with the spiritual aspects, and then consider working with a religious community or authority. Again, that taking that extra step of not only understanding, but considering referrals. Thirdly, one could address spiritual as well as emotional aspects of the problem indirectly, using the patient's own spiritual perspective. What are some figures in their own tradition that are examples of them, for them, of dealing with these issues? And then finally, if you share a spiritual tradition with the patient, it might be appropriate to address the problem directly using that shared orientation. This can sometimes be tricky because it can blur the boundaries between being a therapist and a spiritual authority, and take one off the track of what is most needed for that person from you as a clinician. So I'm going to talk a little bit about the clinical context in which these issues come up. Here's an example. The team requests urgent evaluation of the mother of a 5-year-old girl with leukemia. On learning that her daughter has relapsed, she becomes distraught and asks, "Why did God do this to me?" This kind of existential distress, one would want to explore more. Is this just an idiom of distress for her? Does she have a history of betrayal, in particular by God? It's probably not really a theological question she's asking, but she might benefit from talking with the chaplain. Just more explanation is usually what's indicated. There's a systematic review using a Delphi methodology about the role of spirituality in serious illness and health. The literature was reviewed by Tracy Balboni here at Harvard with a number of her colleagues. And it came up with conclusions that spiritual needs are common in patients with serious medical illness. They ought to be addressed more than they are. And it's important to consider the role of spiritual care specialists, such as chaplains, in addition to educating ourselves as clinicians about how to respond to these kinds of questions. One way to think about spirituality in functional terms is as a resource in existential distress. So some of these existential domains of identity, hope, meaning and purpose, morality, autonomy, and authority can be helped by spirituality, which is engaged, integrated, reflective, mature, and in which the person feels loved. Here's an example. I'll see if I can maybe bring up this brief video involving an interview that Marsha Linehan did with the New York Times about her experience. Marsha Linehan was the developer of DBT, dialectic behavior therapy. She herself had her own mental health history. She was hospitalized with self-injury a number of times. And I'll just try to see if I can bring up that video that illustrates the way that her spiritual experience informed her identity.
I was sitting in the sitting room right outside the chapel, which I will never forget, because I was sitting on the couch, and I think I felt complete and total despair is the only way to say how I felt. And so this nun walked by, and she turned and looked at me and said, is there anything I can do for you? And I realized that no one could help me, that just no one could help me. So I said to her, I said, no, thank you. And she left. And so I got up and I went into the chapel, and I was just kneeling there. And I have no idea. I doubt seriously I was saying anything. I think I was just looking at the cross above the altar. And then out of the blue, out of the absolute blue, suddenly everything went gold, and the crucifix started shimmering, and the room was shimmering. And I had this unbelievable experience of God loving me. And I jumped up and ran out and ran to my room. And I was standing in my room, and I said, I think out loud, I said, I love myself. And the very minute the word myself came out of my mouth, I knew I had been completely transformed. Because up until that point, I would have never said that. I would have said, I love you, because I had no sense of myself. I thought of myself as you. And the minute the word myself came from my mouth, I knew, and I've always known ever since, that I would never, ever cross that line again to being crazy.
So there's a good bit we could talk about there. I think we could come back to it, but I hope you hear the point about her identity being influenced by her spiritual experience here. So demoralization is another condition that we see often in the medical setting. And I'm referencing here a paper by James Griffith at George Washington about the treatment of demoralization, with which he calls hope modules. He encourages the need to conceptualize hope as a practice, adopt a framework of resilience, assess coping during adversity, and utilize evidence-based practices in the domains of problem solving, emotional regulation, activation of a core identity, and relational coping, the last two of which often involve someone's spiritual resources. Also, in moral injury, there's a growing consensus among those who treat sufferers from moral injury that we need to go beyond a psychological approach to a yes and approach that deals as well with issues of guilt, forgiveness, making amends, helping people to engage, again, goodness, creating or expanding groups that foster a sense of goodness. And you can see in this image from a paper by Litz et al. In 2025 about the treatment of moral injury, some of the options for helping patients with this reconnection with a sense of goodness. And these include their spiritual resources. Addiction is another area in which a spiritual approach is helpful to many patients. The 12 steps include several spiritual steps, including making a searching and fearless moral inventory, confessing this to another person. And you can see in the 12-step programs how they address existential issues of identity, integrity, interdependence, in ways that integrate one's spirituality with one's emotional life and struggles. Depression is another area where there's been more explicit, sometimes, integration of spiritual traditions with psychological treatment. Michelle Pierce has written about cognitive behavior for Christians with depression. There have been similar issues within the Muslim community, and I've written more generically about depression and the soul. You wouldn't think that forensic psychiatry would be an area where spirituality has much relevance, but Michael Norco at Yale, who was the president of the Academy of Psychiatry and the Law, in his presidential address, talked about the search for truth within forensic psychiatry as a spiritual quest. And this paper on the right by Linda Ganzini documents the way that forensic psychiatrists' views about how much medical aid in dying was ethical influenced their decisions about the level of competence one needed to have in order to engage in medical aid in dying. One's spirituality can influence one's clinical approach. Psychedelic treatments are becoming much more in vogue in the US. And there's a lot of interest in the ways that mystical experiences seem to be correlated with outcome. Positive mental health, the positive psychology movement, positive psychiatry has contributed to a fourth wave of psychotherapies that move beyond recovery toward growth, well-being. These include gratitude and forgiveness and compassion-based therapies, meaning-centered psychotherapy. This on the right is just an example of the ways that positive psychology interventions, such as gratitude, can promote health outcomes in patients undergoing bone marrow transplantation at my institution, for example. There are a lot of psychiatric ethical issues that arise at this interface between psychiatry and spirituality. The American Psychiatric Association's Ethics Committee recently published in the Journal of Nervous and Mental Disease a discussion of these issues, an overview, and and Oxford published a book a number of years ago looking at ethical considerations at this intersection with respect to different disciplines within psychiatry. There's more recognition now of the importance of clinician burnout and the role of spirituality in maintaining well-being and effectiveness. Robert Wicks is a psychologist who's devoted a lot of attention to resilience among clinicians. He talks about the need for a patient to have, for a clinician to have an inner life and ways of fostering that. Jennifer Radden, who's a philosopher, and John Sadler, who's a psychiatrist, wrote a book in 2012, The Virtuous Psychiatrist, looking at character ethics in psychiatric practice. And we know that many of the virtues are embodied and encouraged by spiritual traditions. When it comes to psychiatric education and training, there are places, psychiatric training programs that have courses on religion and spirituality and ways of helping clinicians who are coming up in the field to develop these skills, but they're not as widespread as one might hope. One of the pioneers in fostering this kind of training is David Rosmarin, a psychologist at McLean Hospital, who has developed this Spirit Protocol, Clinical Training in Spiritual Psychotherapy for Inpatient, Residential, and Intensive Treatment programs. And he's trained clinicians in this country and actually now around the world in doing this kind of integrated psychotherapy in inpatient and partial hospital and group settings. So finally, I'd just like to conclude with a couple of quotes from William James, who was at Harvard here and whose varieties of religious experience is still considered a classic. He said, "Religion is a man's total reaction upon life. Today we might say spirituality," pointing to the relevance of this in so many domains of life. But he also said, "My thinking is first and last and always for the sake of my doing." So I think this kind of pragmatic stance is really helpful for us in psychiatry and in medicine generally, in thinking about how we engage spirituality. How is it going to serve the patient? Where is it clinically relevant and relevant to the helping us do the work that we need to do? So I'll stop there and thank you for your attention.
Thank you so much, Professor Peteet, for this really very interesting and exciting approach. And I will try to, if you have some time, to translate some of the questions that I received. The first one says, assisted suicide. What is your approach in case you're asked by a terminally ill patient?
Well, it's not legal in my jurisdiction at the moment, but in two of the states that are near us, it has become legal, and one of them, Vermont, has dropped its residency requirement. So individuals can go from Massachusetts, where I am, to Vermont and go through the process. And so we are getting more questions about this now. I usually try to understand what is really driving this. We know from the literature that there's the concerns about autonomy and avoiding becoming dependent on someone are more important than issues of physical pain for people who are pursuing medical aid and dying. And so just exploring more what their fears are, I think would be the first thing that I would do. We let people know about their options if they ask us, but it's not something that we're encouraging as an option, which I think has sometimes happened in other places. I hope that answers your question.
Okay, thank you. The next question says, you talk about mystical experiences. What is your belief on mystical experiences of some monks, religious people, etc.?
Well, there's a long tradition of wisdom coming from mystical experiences, and mystical experiences being a resource for people emotionally. I don't consider myself an expert in that way, but I think when patients bring those to us, it's important for us to take them seriously, to let them know we're interested in hearing what they may have learned from them. Often, I think patients are reluctant to bring up these issues with psychiatrists because they connect us with Freud and his anti-religious attitudes. And so just asking at the beginning of an assessment about someone's spirituality, have they been a spiritual or religious person, I think shows an openness to hearing more about these experiences. And some clinicians will ask, have you had any unusual experiences in your life that were especially meaningful to you? And when we do ask, it's surprising how often people have those experiences and how meaningful they were. And as I mentioned, we're getting more interested in these issues when it comes to psychedelic experiences and psychedelic treatments.
Thank you. And then the last question is, the new bibliography on the role of microbiome on neurological and psychiatric diseases is strengthening your efforts of science being closer to religion than before?
Yeah, I know that's an emerging area of interest. And I think it speaks to the relevance of seeing the whole person and thinking about health and lifestyle factors as being important. And I think spirituality fits into that rubric of ways that one's whole life has a bearing on their emotions and their psychiatric conditions. I don't know of direct connections between gut health and spirituality, except that it is true that within certain spiritual traditions where you have healthier diets, it's possible to document better health outcomes. And it seems as though that's one of the pathways by which spirituality can be associated with better health outcomes. There are other pathways as well, but certainly physical health, exercise, use of substances are indirect ways that spirituality can improve health.
Thank you so much again for your time and for offering the Greek audience your vast experience. And we want to express our gratitude and hoping that next year we'll have you again with a new topic. Have a nice
Thank you so much for
day.
your interest.
Thank you so much. Thank you again. Bye-bye.
Bye.